PET CT imaging in our patient 3 months after the completion of his induction therapy showed a partial response, and that was shown again at the 6-month mark. So unfortunately, our patient did not get a complete response to the BR therapy, which happens in a percentage of patients. With BR induction, I would expect 60 to 70% of patients to go into complete remission, but that means 30 to 40% will achieve no remission at all or only a partial remission. And we know partial remissions do not last as long as complete remissions, to immunochemotherapy at least. And so we could expect this patient's remission will not be very durable. In addition, our patient continues to report symptoms of fatigue, and so the decision was made to start him on therapy with ibrutinib. So the question really is, what do you do in a patient who achieves a partial remission? I think ibrutinib is a very reasonable choice here. There are a few other things that could be considered. Maintenance rituximab perhaps could flip this patient into a CR. Rituximab given with lenalidomide might be able to flip this patient into a CR. The data for ibrutinib is probably the strongest of all of those options. Ibrutinib is FDA approved for recurrent mantle cell lymphoma. It has an overall response rate of about 60 to 70%, with about 20-25% being complete responses. There's not a lot of data for how well it performs in this exact setting, like you take a patient who has achieved a partial remission and then you put them on ibrutinib therapy in that situation. But I would think that ibrutinib therapy would be quite efficacious in this scenario. Ibrutinib is generally well tolerated. Some patients experience diarrhea, myalgias, arthralgias. Those tend to get better with time. We do see some patients experiencing atrial fibrillation. The risk of that appears to be around 5%. One thing I've noticed with ibrutinib as I've gotten more experience with it over the last few years is hypertension. And this, in my experience, has been kind of difficult to manage, so I do think that's something that has to be monitored in patients on ibrutinib. It's oral therapy. Patients tend to like that. The dose in mantle cell is 560 milligrams a day. And the hope in our patient is that it will convert him into a complete remission, and then we would just keep him on the ibrutinib therapy for as long as we can, as long as it's tolerated and as long as it's efficacious. And so if the patient is tolerating the ibrutinib therapy well and he stays in complete remission, then we would continue the ibrutinib therapy in a case like that indefinitely. Other options for our patient would be to change him to a completely different kind of chemotherapy, like R-CHOP or add cytarabine or something like that. Certainly an option, but he just went through 6 months of immunochemotherapy and he's 72 years old, so that's not highly attractive. Lenalidomide Rituximab is an interesting option. There's no question that lenalidomide by itself has good single-agent activity in mantle cell, and it has an FDA label. The data would suggest that lenalidomide works much better when you combine it with rituximab. So when I give lenalidomide in instances of mantle cell lymphoma, I always give it with rituximab. They really seem to synergize. So that's a good option, I think, for this patient. Bortezomib would be another option. Bortezomib is FDA approved for recurrent mantle cell lymphoma. It has good activity. I wouldn't say it's great activity, but it's good. Peripheral neuropathy is the thing you have to watch the most for with bortezomib. Of those 3 options, bortezomib, lenalidomide, rituximab, and ibrutinib, I think ibrutinib is probably the most well tolerated, although it's a close call with lenalidomide rituximab. But I think any one of those 3 would have been reasonable here. But I still think ibrutinib is probably the most attractive choice for our patient.